Let's start by asking the women themselves, the girls, the communities, what do they need? What do they want? We have what it takes to be able to do what is right. We really need to get serious also as Kenyans, because I feel like we are getting a road deal, but we are not taking it forward.
Not enough information has been given about this new system. You just can't wake up and put together a system that you say has not been working without one consulting the people who have been using the system themselves.
Women told us that they want respect and dignity. Women say they want to be told what is being done to them. Women told us that they want to be called by name. They want to be given the information that they need to make the right decisions and they like. They want to come and deliver in a clean facility. They want to be talked to nicely and they like. They are tired of being slapped and they like.
To them, they actually justify it as a means to ensuring that, one, the woman does not pass out when she's in the process of giving birth. So they say we have to beat them up so that they keep pushing. You understand? So to them, they justify it as a way of ensuring that
helping them to
yes,
deliver.
Yes, they say if we don't beat them up, the woman will stop pushing.
Welcome to Willow Health Media. My name is Dr. Mercy Korir. It is a knock behind hospital doors, tracing medics' journeys into medicine to reveal the passion and patience, aspirations and sacrifices behind each white coat. From midnight crisis to lifelong choices, it uncovers the emotional, ethical, and personal battles that shape their hopeful hearts and healing hands. Thank you for joining us on Lifeline Dialogues. Today we are talking about maternal health, and we are getting to look at whether the lives of mothers is as important as we say it is. Joining me for this discussion is Timothy Thondu, who's the legal advisor for the Center for Reproductive Rights. This is a human rights organization composed of attorneys working to ensure that reproductive rights are protected. Also with us is Angela Nguku, who is the founder and the executive director of the White Ribbon Alliance, Kenya. This alliance advocates for women's and girls and gender equality. So just to start off, as we are preparing for this conversation, just trying to look at the statistics around maternal health. And I find that, there is no central source of truth, if I may call it that, that can authoritatively say these are the numbers. If you look at the Kenya Demographic and Health Survey, it has a different number. I think it was 355. If you look at the global estimates, it has it at 530. So do we really take maternal health as seriously as we say we do if we don't have credible data? Let me start with Angela, then Timothy.
Thank you so much, Mercy. I think we have a problem. And we have a very big problem. First and foremost, because even as we talk about maternal health, okay, let's talk about maternal deaths, because that's what you're referring to.
Yes.
It's most of the data that is there is not current. It's not real time. We can't say we have real time data. So we are still talking about DHS of 2022. And even as we're talking about the DHS, the averages are masking inequities and inequalities across and among counties. Interestingly, when you come to the UN bodies, we have different data from UNICEF, from WHO, from UNFPA, which to some extent I tend to believe because I think they go deeper to get into the counties that are left out. So I tend to believe that data more. But I think there's something I keep mentioning, and I say this at White Ribbon Alliance, especially because our focus is really on the qualitative data. That is what is not spoken. I have a strong belief that behind the numbers are lived stories and realities of people that no one surfaces, no one brings to the fore. And even when you look at the data that is given, even in these other documents, the stories behind those numbers, the diversity of women, because women are not homogeneous, mothers are not homogeneous. We have adolescent mothers who are really left out completely. They're left farthest. We have women and girls living with disability who, in our programming, even in my own training, as I was being trained as a health worker, there was no way I was told how to deliver a woman who comes with a disability to me. So that is left out. They are not counted, because they are not even programmed for. They are not in policy documents and the like. When you talk about women and girls who are from indigenous groups, the nomadic groups, they are mobile. Nobody thinks about where do they go. Do they cross to Tanzania? Do they cross to Uganda? Do they go where? Who captures that number? And who captures their realities and the like? So looking at what is existing, first, it's fragmented, and it's really like not real time. Number two, it does not capture the realities of the people. It does not capture the lived experiences, the stories, the realities. And I can tell you, for the last 6 years that I've been running and working at our White Ribbon Alliance, because our work is really focused on surfacing the issues as for the people, the self-articulated needs of women and girls, of mothers, of newborns, of families that have been left out. We've established the gaps that they are so deep that nobody speaks about. And no wonder our clarion call and our approach now is, let's start by asking the women themselves, the girls, the communities, what do they need? What do they want? Then listen to them, not to respond with our own preformed ideas and the like and theories from researchers which are neither here nor there. We prioritize with them what are the key gaps that are really existing in the maternal newborn health agenda. Then after that, can we act on these priorities, not acting on what we sit in our air conditioned rooms and assume we know what they want. We know their realities. Because until you ask me where my shoe pinches, you will always get me the wrong shoe.
True.
So at the end of the day, are we really getting to the core of it? And I call these the real experts because these are the people who know their realities. They live their experiences. They live their context. They know what is best. Rather than really just deciding, oh, if the number is this, it's an average. Okay, now we need health facilities. Have we gone to those people and asked them, what are your realities really? Maybe they just need literacy to understand what they need to do when they're pregnant. They don't need a health facility that has no health worker, no running water, no food, no security, no roads. What exactly are we doing? So I think even besides the data that is fragmented, the data does not paint the true picture of the lived experiences, the realities of the people. And we really need to realize at the end of the day, until we understand the needs and until we understand that all these women are not one woman. It is not, it's not an average women, or let's talk about women 35 to 40. It is women in their diversity, women coming from different places, women with their specific needs, and until we understand their needs, we'll keep on getting it wrong. Yeah.
Timothy, in this day and age where technology is, everywhere, why don't we have credible data?
Thanks. And maybe just to echo what Angela has mentioned, I think over and above the credibility of the data that is there or that is not there, even the data itself, whether credible or not, is not also sufficient or is not existing, which is a very big problem. And for me, particularly speaking from a legal standpoint, is what is the problem that we have with lack of data? And I'll stem from the point where, you see, when we're trying to address some of these maternal health violations and some of these things, what we seek from whoever we are seeking accountability from is, one, accountability for the violations. Number two, redress. And for you to be able to seek accountability and redress, then you have to use a system where you're telling the person who is violating that you are violating these things based on 1, 2, 3 things, and you show them the data. And that's the importance of the data. Because when we go to court, for example, as a Center for Reproductive Rights, among the things that we argue in court is there has been too many deaths caused from either unsafe abortion or maternal health care violations, women who are not being treated as they should be when they go to give birth in hospital. So when you tell the government, or when you're suing the government, or you're telling the government, you need to be accountable for some of these violations, the primary thing that you need to have on your side is data and credible data. Therefore, when you don't have this data, then it also poses a challenge in terms of accountability and redress. You cannot be able to call out the government and tell them, no, you're causing some of these violations, and this is the data that we have to show that 300 women in a certain part of the country are dying because of unsafe abortions. So I just wanted to mention and clear that the problem of insufficiency in data, it doesn't just stem from creating more problems, but it also makes it very difficult for us to be able to seek accountability and redress from the people who are violating. But on to your question, you asked about technology. I think we are in an age where technology is either meant to serve us or we are serving technology. I think we are in that phase where we still don't know what is happening.
Trying to figure
But allow me to use an example of where technology has helped in terms of accountability. So in one of the cases that we did in Bungoma, it's a famous case, it's called the Josephine Majani case. Josephine walked into Bungoma County Hospital, and when she went to give birth, there was no availability of beds for her to be able to sit down and, or rather, for her to be able to be cared for up to the time when she needed to give birth. So when the moment came for her to give birth, she was told, walk it to the delivery room, and when you get there, hopefully somebody will be able to assist you. When nobody was coming to get her, Josephine, when labor pains became increasing, she decided to walk to the labor room. When she got to the labor room, she found the labor room was also full. Other patients were being attended to. And as she was walking back, she fell down on the floor, unconscious, and delivered her baby on the concrete floor. As she was in the process of doing that, she met with nurses. When she woke up or when she regained consciousness, she woke up to insults and beatings from nurses who were asking her, why have you soiled the floor? So the concern was not why there was no nurse to take care of her or why there was no person to help her in the process, was why have you soiled the floor? And this is where technology came in. So that story came to light because there was a lady or a woman who was on the other side of the bed or on the other side of the ward who saw what had happened and was able to record the happenings and shared that with one of the media houses in this country. And it is from that we were able to receive such a case, and we were able to follow up on it. I just wanted to mention in terms of, I think the use of media in collecting, it might be data in terms of systemic problems, or it might be data as little as the experience for Josephine Majani from wherever she is. That whole process, I think technology would play a role in it. I think we probably are not harnessing it enough for the benefit of, especially in this context, healthcare. So
when I was starting my medical practice, maternal, and you'll corroborate this, Angela, maternal mortality, for example, was a reportable issue.
Yes.
That if it happens in your facility, whether it is within the facility or a mother has come, it's reportable. We had so many forms to fill in, and it was escalated all the way to the national government. So is the same thing happening? And the reason I mentioned technology is because now it should be on a click of a button that information has been relayed.
Yeah.
So we should be able to have real-time information, because I don't expect that, the forms we filled 12 years ago are still the same ones that we do. So that's the kind of thinking that I have in terms of just maternal issues, not just maternal mortality, but also issues of, unsafe abortions or, post-abortal care, talking about postpartum hemorrhage. Those that if we're really talking about maternal health being a serious concern in the country, we should be able to leverage technology so that we have real-time data in, collecting this information and doing something about it.
Yeah. I think, interestingly, it would be a very wild assumption to assume that we are there yet in terms of technology advancement, especially within our facilities. I haven't interacted much with facilities around the country, but what I can tell you for sure is that even those integrated systems, or what systems you would assume would be working in terms of relaying that data to a central place, either at MOH here in Nairobi or something of that, is probably not there as we would think of it. And why I say that is because if things like drugs within a facility are a problem, that you go to a hospital or you go to a facility and you're seeking to give birth per se in the process, and you're asked to come with cotton wool and things like that. So you can imagine if that is a level of inadequacy within basic things that you will require within a facility are not there, what then would you mean that a doctor has somewhere a computer that they are relaying that information straight to Ministry of Health? You get that, what I mean? So in terms of, there are some things that ideally would be the ideal situation, but in the current circumstances that we find ourselves in, even what should be the normal basic care, basic quality care is not there. So even that which we anticipate or we say we should get there is also non-existent. So for me, I think from my experience, even the basic things that we have within our, especially within our default system of health, is absent. So I would not even get to the point where I ask whether there is technological advancement in the sense that they can be able to relay that information. And just to mention, ideally, and I agree with you, some of this reporting ought to be done at real time. Information regarding maternal mortality, all these things is something that once a doctor receives a case and a case has led to maternal mortality, they're supposed to record it, and that information is supposed to be transmitted. But in most instances, when one for one reason or the other, maternal mortality has been caused by either negligence of the doctor, or you also don't expect that they will also transmit that information. So one, it's an inadequacy of the system, but also inadequacy of quality care that leads for them not to report some of these cases. So I think for me, that is where I would place that.
I think I don't know whether I can also come in there.
Yes.
I tend to think it's a decision not to do what is right. I say this because we go to private health facilities. How comes data is real time? And what changes really? And what is different? What is such an investment that is so needed? We have what it takes to be able to do what is right. I think for me, what is there is the will to do what is right. And the will stems from the political will to whatever other will that is there really to ensure that we invest, to ensure that we do what is right. And I say this because a lot of times you hear people saying, oh, we need a lot of money to carry to do a survey to understand what is going on. But I actually have come to realize we don't need. I'll just give you a scenario of what we do. When we started doing what we call the What Women Want for quality reproductive health care, at first we started in 2018, 2019, and we were doing it using paper surveys. And we were using mobilizers from across the country. Those are people living in the communities and the like, simple trainings and the like. It was quite expensive. But then we realized, we can harness technology. We have smartphones. At least we have people across all these places, name it, whether it's Lamu, whether it is Turkana, wherever. You can actually get people with smartphones who can be able to populate that survey document and send it real time. It made our work so easy. In the last 2 months, we've collected data from 97,000 women from across 46 counties in this country using just that smartphone. It doesn't have to be really complicated. We have gotten real-time data, and we're asking women, what do you want most for your health and well-being? And where are you in terms of health literacy? And we have that information that is being collected from ages between 10 to 75 plus within a span of less than 2 months. We have data that can be used to do so much. We use the list of investment. The government has the machinery to do whatever it can to get all that right. So I say it's a decision, really. I think it's a decision not to do what is right and not to invest and really hide in the bit of, we have this. And then I think there's also the element of the citizens themselves, of the people who have been kept in the dark. I keep asking this question: why is it so hard to educate the people, the citizens, on what is the public good, the social good, like education, like health, like all these things, so that they can take charge of their health, but also demand for accountability. I look at the civic education during elections. How comes it reaches everyone? We are taught about electing because it's electing the critical few people we are basically supporting them to get into a system that they want to come and keep us in the dark. So why have we never thought about demanding for accountability, for civic education, for what is really basic for us? For public funded things like health and education and all these things, why are we still allowing ourselves to really get it wrong? To get the raw deal from the people that we've elected to get us to the right place, or the decision makers. They don't necessarily need to be elected. They are decision makers who are in the right place to ensure that we are getting it right. They teach, oh my God, there's so much money that is invested. Everything is about IEBC, everything. But how comes we are so apathetic? We're all thinking Serikali's idea. We don't really come out to ask ourselves, why are we not being told the same about this CBC that everyone is complaining about health, that is a basic human right, that environment and all that. We really need to get serious also as Kenyans, because I feel like we are getting a raw deal, but we are not taking it forward. Yeah.
Are there things that we've gotten right as a country, as a community, when it comes to addressing maternal health?
I think what we are getting right is coming from, I can't say it's coming from the public facing. I think it's coming from now the civil society organizations coming together to really work with communities to demand for accountability. And one of the ways that I think is really going to work, and I think is something that is being started, and we part of that starting, is ensuring that people understand their rights and entitlements when it comes to their health, and demanding. I can give examples of different counties that we are working, like in Bungoma, Vihiga, Kisumu, and Kakamega, where we are educating masses on their self-care, their self-rights, the power of organizing, self-advocacy, and really like coming out to understand what are your rights and entitlements. If I go to that health facility, what am I supposed to do? Like Josephine, what Timothy is talking about. If she knew her rights, she should not have been shouted at. Even me, I was not trained to shout at a patient. Where do we get to a point where we start shouting? Even when do we go beyond the ethics to really start now shouting on the like? And so we are training on respectful care. We are training on literacy around what to prepare for before pregnancy, during pregnancy, and after pregnancy. When you go to the health facility, what do you expect? And we are not doing it just for the community. We're also doing it with the midwives, the nurses, the doctors themselves, and also the county. Such that we found a very interesting thing. So we went for a visit last 2 months ago, and we went and we actually met communities, and the county was telling us, you know what? We have actually had to transfer people and even demote people because of what we got from the communities. They told us that they are getting a raw deal in that health facility. For me, that is change, even if it looks small. It's a piece of change that can be translated across board. Yeah.
Yes, I think, and I agree with Angela, but I also think what we've gotten right as a country is also on the legal and policy environment. I think in Kenya, when you look at and comparing to our peers within the region, Kenya's laws and policies around health are actually very robust. I think beginning with the constitution, when we codified the right to health as a fundamental human right, and then we step from just the right to health and then enter into the realm of reproductive health. And all these are constitution rights that are within the Bill of Rights. So I think in terms of what we have within the legal and policy framework, I think we've done a tremendous job in terms of putting together a legal and policy framework that is enough to support a robust health environment. When we talk about guidelines, when we talk about policies, really, I think we have done a good job in terms of putting there. I think the main problem that we always have is we have very good laws, but implementation is always a problem. But in terms of doing things right, I think Kenya has gotten it right, really, in terms of putting together a proper legal and health framework. Of course, there are some aspects that still remain ambiguous when we're talking about a legal and policy framework around issues such as safe and legal abortion, which still remain within, we can't say adequate environment, but in terms of general healthcare within our country, I think our legal and policy framework is good enough to support a healthy environment if we are to implement it.
Okay. I think the other thing, Mercy, I think it's a devolution bit, the decentralization, where we have health facilities at different levels at different regions, which was not there in the past. Whether they're functioning or not at that level is another story. But that alone, if we can be able to work within the policy frameworks, ensure that we're actually budgeting, ensuring everything that implementing to that level where we are reaching everybody with the devolution and everything, I think we can reach the masses with the quality healthcare that they need. Yeah.
So I wanted to follow up on the policy conversation. Yeah. Of course, SHA right now is like the biggest policy that has disrupted the healthcare system and the healthcare space. So yesterday I was just having a conversation with one of my colleagues in our facility here, and one who represent facilities. And the issue is, mothers are suffering because either they are not registered or they don't know what to do with the system. Teenage mothers are also at the pain points of, the new system because they don't have an ID. And it's not their parents who are delivering. And here's a child who's coming who needs, care. And there's been a lot of, issues around that. I don't know what your thoughts are on this and, what you're doing in the current scenario with it. Well, the government still calls it teething problems, or the Social Health Authority. Let me start with Timothy.
Yeah, and I agree with you. And I think from our perspective, I think the biggest challenge that we've had with She and Sha is the Linda Mama initiative and what that meant for what the government had provided for. Because under NHIF or under the system that was there before, Linda Mama was working to some extent. At least people could be able to get some level of healthcare. And then now you come in with a new regulation, a new authority. And I think among the many problems that people have with the current system is that not enough information, and I think Angela alluded to it, not enough information has been given about this new system. You just can't wake up and put together a system that you say has not been working without one consulting the people who have been using the system themselves. You can't sit as government and say, for us, the one thing that we want to deal with is corruption within NHIF. But are you asking the people who are actually using this system, is it working for you? How has it worked for you? What can be improved? Because ideally, for you to change a system, you're supposed to improve the system. If something is working, there's no need of changing it. And even just on the issue of information, and I think I was hearing of a conversation somewhere and said, the moment the government decided to change the currency in our country, every single person in every corner of this country knew about it. The government went to extensive lengths to ensure that everybody had information about the fact that within the next 3 months, we are changing the currency. So if you have the 1,000 shillings note that is old, you will not be able to use it. My grandmother in the village knew about it. Immediately she knew, because she knew pesa ambayo niko nayo will not be of help to me in the next few months. And that was a government initiative. It is not bloggers or social media influencers who they used. It was a government-run initiative. So they can't say or sit and say that they cannot be able to offer this information, because a lot of these things are actually stemming from a point of people do not have the information on what and where and how this system is going to help them. And in the absence of that, then definitely you can't say it's going to help them. People will walk into hospitals, they're told you have to pay for it. The government says, no, you do not have to pay for this service. The confusion, which is causing a lot of problems. And a lot of these problems stem from lack of information. So for me, I think the basic problem that I have with the system currently as it is, especially with regards to what was working and what is now there, is that the government did not do enough to share this information, to involve the public into what needs to be done, what needs to be changed, what is working, what is not working, how can we be able to change about it. Yeah.
I think I totally agree with Timothy. And it's interesting because yesterday I was in a place also, there was a conversation that was going on, and we had a representative who had come from that authority. And it was interesting to hear this, that at some point, I don't know where, because I also don't have all the information. Just like Timothy is saying, we there are many people who don't have the information, that someone has to get into a system and log in the details and log. And I was sitting there wondering, wait a minute. So that woman who's in that Dadaab refugee camp, or that woman in Lamu somewhere, that as in, the assumption is that the elites, because they can, we think so much theoretically. We think because I have this smartphone that I can. The majority of the populace can actually do that. And for me, that is where it pains me. Because the assumption is that because it has reached us on the social media, it has reached us on TV and the like, we assume everyone has a TV, for example, has a radio, has everything. And I honestly think it's so wrong, where a few people sit and decide for the masses, and then they're like, it's okay. But we understand the last mile, how far this goes. I'll tell you, I totally agree with you, because we work with groups. We work with Women and Girls Action Networks for Change across the country. And we've been asking them, how is the experience? And they're like, they wish they can get their Linda Mama back, because it was helping them a big deal. And then we're like, why? Like, because no one has told us about this new thing. First, it looked like it's a government thing. You see, when you don't involve people, they no longer own it. If they had been involved, they would own it, and they're like, they would also be the ones helping the government to educate the people who don't know. But now it is, for a few, it's almost, it sounds punitive. If you ask people, it almost feels punitive, because I was in that forum and they're like, okay, anyone with a question, people are like, so many questions. We have so many questions. Have you understood? No. And these are the elites in that room. Now imagine those people in the villages, those people in the communities, those people who are not so far away from us, but they don't also understand it. And I think what we need to do is actually stand up and say there's a problem, and say, and be able to face it and say, how can then we fix it? I wish someone actually can, who is within that authority, can ask, this is what we are hearing. How are we responding to the feedback around it? We can't keep on saying in the next 2 months. There are people who are pregnant, or pregnancies don't stop. There are people who need help. There are people who are on cancer drugs. There are people who need physiotherapy. There are people who need so much. Can we just say, let's wait? So we let these ones die, and then after 2 months, when we've resolved the ones that are alive, the ones that we really need to ask ourselves very hard questions as a country. I feel there's a problem somewhere. And why are we rushing to? Where was the rush? Because if you ask me, if it's dealing with corruption, did NHIF, there are many systems of dealing with that. Was that the best way of dealing at the expense of millions of Kenyans that are now going without healthcare across board? We were being told in some places, I think it was in Kajiado, it's Narok, that people have stopped going to the facilities because they don't have NHIF. And they go there and they're told, no, we can't, there's nothing that is functional. So they're going back to the traditional birth attendants, they're going back to deliver at home, they're going back to the same old care they are basically regression of gains that we've made for such a long time. Yeah.
So now, in your opinion, what should be done in order to save lives? Because with the information asymmetry, obviously people are suffering. Is there anything that you can do within your own spaces to be able to help? And especially, like you said, like if a pregnancy is going to progress, if it's labor, you can't stop it. There are things that have to be attended to. So is there anything you're doing in your own spaces in order to be able to help? Now that we have the Social Health Authority here, and it's not going anywhere anytime soon.
I think there is. And there's something I keep saying, that at the end of the day, this woman, this mother, this family is out to seek for better health outcomes for themselves. The same thing that the government, whether it is the providers, whether it is the policymakers, whether it is the decision makers, everybody says we want the quality health outcomes for these people. So we have a common denominator, better health outcomes for everybody. So the question is then, and I think the thing that I keep on saying is that, can we have the people, the users of care, who I call the real experts, because they're the majority, they're the ones who know what they want, the providers of care, the policy makers, the programmers, the resource givers, sitting on the table to actually have a conversation, vis-a-vis where the users of care are left on the one side and they are just given whatever comes. And nobody goes to ask for feedback. What do you think? They're just left there. Whatever we are prescribing this, we prescribe. Is there a place of conversation and consultation? And that is what we actually push for at White Ribbon Alliance, where we talk about, can we really start with asking the people, the users of care, what does it look like? And I think in 2017, 2018, a report, I think a Lancet report on quality of care in the SDGs era was done. And I was privileged to be part of the People's Advisory for that report. And one of the things that really came out strongly is that people-centeredness in care is really critical. A few years later, I think not 1 year later, 2018, the confidential inquiry into maternal deaths in this country was done. That surfaced that quality of care was the problem. 9 out of 10 women who died in Kenya died as a result of poor quality of care. And when we went deeper to understand, then what does quality of care mean to women and girls? We did a survey across the country and across board. We reached 137,000 women from across the country. And we asked them, one question, what does quality reproductive health care mean to you? And let me tell you, what we had was really so far disconnected from what the policymakers and programmers think. Women told us that they want respect and dignity. And respect and dignity means serve me on time. Do not open clinics in the morning. Open them in the afternoon, because in the morning we are taking our children to school. We are doing, and honestly, at the end of the day, we should be responding to the user's needs, not the supply side. It's not about me finishing work early. Women say they want to be told what is being done to them. Women told us that they want to be called by name. They want to be given the information that they need to make the right decisions and the like. They want to come and deliver in a clean facility. They want to be talked to nicely and the like. They are tired of being slapped and the like. That is what quality to them means. And it determines whether they'll go to the facility or not. Women told us that they want water, sanitation, and hygiene. They are tired of being in dirty places, dirty toilets. I was really touched by women in Nyalenda in Kisumu who talked to us about, especially the ones who are living disability, because we reached women in all their diversity. And they told us that when we go to the facility, we are made to wade in the locky. I think you'll understand that, Mercy. That it's dirty, it is stained with, it's disgusting. So they get infections and the like. They are slapped. They are told, who told you to get pregnant? There are no disability-friendly beds. Honestly, no one trained me how to deliver a woman again. Sign language interpretation is a problem in this country. Does it mean that these women don't deserve the quality care that they need? So imagine if we had gone back to ask women what they needed, what quality means to them, and we spoke with them, we would be making policies that are really progressive, not retrogressive. They told us that they want health information. That was the third ask for them for quality. Health information to make decisions before, during, and after, including women with chronic diseases and the like. For me, and so much and so on. They want life-saving commodities and the like. They want proper working roads, because during the rain season, some roads are impassable. Women in Mathare and some of the informal settlements in Kenya told us insecurity is a problem. It's a definition of quality. Why? Women, labor for some reason comes at night. They can't go to that Mathare as much as it's so well functioning and the like because of insecurity. So are we listening to respond to quality from a multisectoral perspective, or just it's a health whatever? And that's why I keep saying that health is not a health ministry issue. It is multisectoral. And until we listen to the users of care, we'll not be able to understand the economic power of women. Women are like, we want to be able to pay borders to go for ANC. We don't go because we don't have the money. Who responds to the economic needs of women? Who thinks of it even in that perspective? So for me, until we can be able to have the users of care, speaking to the policymakers, speaking to the providers of care, speaking to the people who make budgets and the like, to the policymakers at whatever level, then we are not going anywhere. And if we really mean that all the outcomes that we want, the people want the best health outcomes, the policymakers, programmers, everyone else wants it, why can then we have a conversation? Really, if we mean business. Yeah.
And if you look at the definitions of quality of care by women, they're really simple things that don't need any investment. I mean, it's just having continuous training, say, of nurses and doctors in facilities, having a clean facility. Like, how much does bleach cost? That, to clean the facility, really. Or how much does running water cost? So if you look at, those definitions, they're really very basic and don't require any heavy investment.
And I agree with what both of you are saying. And maybe allow me just chime in on that in terms of even the level of investment that is required. In the Josephine Majani case that we spoke about earlier, when we went to the Court of Appeal, the arguments that had come from the county government of Bungoma was that what we call Article 43 rights, which are socio-economic rights within the Constitution, are rights that ought to be progressively realized. Yeah. That means that there are things that cannot be realized immediately. So they can say that you can't, let's say, for example, healthcare, you can't say that immediately you need to build a hospital, because understanding the nuances of what it means to budget, to plan, to all those things. So the drafters of the Constitution, in their wisdom, realize that some of those socioeconomic rights, with the development in government and the development in systems, might need to be progressively realized, in that you give them a bit of time for them to make steady steps to move forward. And that was the argument that the county government of Bungoma came with, to say that some of these rights should be progressively realized. But what the Court of Appeal was very interesting in saying is that there's something they call the minimum standard of care. For Josephine, abusing her, you do not need a budget within the health system to say we will not abuse a mother coming to give birth. You do not need a budget to say that we will not slap a woman when she's giving birth. You do not need a budget to care for a woman who is coming to actually give birth. Some of those things, and that's what the court said, there's yes, progressive realization of some of these rights, but there's something that we call minimum standard of care. And for the minimum core obligations of the state, some of them include dignity and qualified medical health care. So that you do not argue that you need to put together amounts of money, pass them through the budgetary process for you to be able to give access and quality to some of these women who are coming to there. So I just thought it would be important to mention, and the courts have actually codified that as something that there are some minimum standards that ought to be met, especially within the healthcare system, that do not need to be progressively realized. Those are things that should be immediate. And us should know that when a woman presents herself for maternity health services, she does not need to be abused. She does not need to be slapped. She does not need to be all those things.
And you know, the thing about that, and, you know, getting feedback from our audiences and even just interacting with people, the same healthcare workers in the public facilities behave differently when they're in the private facility. So how come? Are the people seeking care in the public facility lesser Kenyans, lesser mothers than those seeking care in the private sector? Because in the private sector, I don't think I've heard of anyone being slapped or being, you know, abused when they're coming to give birth. So why is there that, you know, lesser mothers or lesser women than the others?
Yeah, I think it's a sad reality. Number one, of course, because they also know, because the assumption, which is very skewed, is that those from a different level of society would not be able to seek redress or call you out on some of those things. They know if you do that to a woman in a private health facility, the first thing you'll see on your desk the following morning is a lawsuit. Yes, from a lawyer, because they're saying you did want to do. And it's because, and we go back to the conversation of information. Do they have information? If even a woman who is as indigent can be able to stand up to a nurse from the very depths of the lowest slum in this country and tell them, you're not going to beat me because you have a right to respect me as a woman coming to look for quality healthcare. But most of them, to some extent, do not know that some of these things are actually violations. Because to them, the way they sell it, and I had this conversation somewhere within Central Africa, where some women were interviewed, and some of the midwives were interviewed on why some of these things. And to them, they actually justify it as a means to ensuring that, one, the woman does not pass out when she's in the process of giving birth. So they say we have to beat them up so that they keep pushing. You understand? So to them, they justify it as a way of ensuring that...
helping them to deliver.
Yes, they say if we don't beat them up, the woman will stop pushing. So you ask, what correlation does you have beating up a woman with pushing? There's nothing difficult with telling them you need to continue with the process. But why do you have to beat me? So some of those things, and just to go back to... So a lot of it is because most people lack the information and lack the knowledge that actually this is a violation of your rights. And that is why they end up in that spaces. And when you compare private facilities and public facilities, it's the same thing. A lot of women who go to these public facilities perhaps do not have the information that what is happening to them is actually a violation. So if they are told come with cotton wool, they'll assume that is part of normal. The process. That is what I need to come with. But if you go to a private facility and tell a woman who's coming to give birth to come with cotton wool, they will look at you in a very funny way. So I think for me, it stems from, to some extent, lack of information.
I think maybe on the side of the healthcare workers, and I agree with what Timothy is saying, there's a culture and of disinformation and misinformation that has existed, that has been passed through generations, either on the side of the users, but also on the side of the people who are providing care. We are working, and for the last 3 years, we've been implementing a respectful maternity care, community respectful maternity care a program across 4 counties. And one of the things that we are working, as I said earlier, with the women themselves, with the administration, with the local communities, with the local groups, with the women, with the health providers themselves, but also with the county leadership. And it's something that has really been embraced across board. And there's a lot of change that we are seeing, where they have conversations around, why do we do this? Is it even right in the first place? And we have become champions of change for that respectful care across board, where they're also working with the mothers themselves. In case there's someone who is propagating it in the counties, then they're able to pass it over to the county leadership and also to the administration of the health facilities for something to be done. And that has really transformed, because the women feel that now they have the power to speak out. They're not going to be bullied as a result of such speaking out, because they have told us that before, when they have been left out, no one has attended to them. But because they are working as a mass, it's a community thing. It's no longer an individual. It's one community, a community having the knowledge, the healthcare workers having the knowledge, the county having the knowledge. Then there's already a progressive where, even if I'm not treated here, even if I have a place where I can go to. But it becomes painful where you have the information, but when you go there, you're not going to get any good treatment that you deserve. So for me, I think if we can be having the information on all sides, and we support this for quality, because quality, equity, and dignity is a right. It is not a privilege. It's not something that you can say, I'm giving it to you, I can take it away from. It's a basic human right. So that should be propagated across board. And it should stem from ensuring that those policies are really understood. Because the question around policies is also around, are they disseminated? Yeah. Do people even understand them? Are they still gathering dust in our offices? Because they keep on being made. They keep on being reviewed. They keep on being, guidelines being developed. Toolkits are being done. But are they really doing the work that they're supposed to be doing? Or are they basically just enriching a few who go for these workshops for their development, for whatever, at the expense of the mothers that are supposed to be getting the care?
Yeah. Sometimes they're, like you said, they're done in well-aerated boardrooms, and they stay there. So in as we conclude, what would you say, and I'll start with Angela, what would you say is your vision for us as a country taking women's lives seriously? What would be the 2-3 parameters, in your opinion, that you'd say, now we are taking this women's life seriously?
I think a good question there. One of the things is first understanding, being deliberate and intentional in understanding where are we and why are we here. Because until we can understand where we are, we can just be planning for what we don't know. And then asking ourselves, and why did we get here? What really went right or went wrong? And then taking it up from there. And not just doing it alone. It's not a few people, but bringing everybody to the table. Remember, it's a whole stakeholder thing. And the stakeholders are not just the ones who are supplying the care. They're also the people who are using the care. Ensuring that there's a conversation around that, a very intentional conversation around where are we, why are we here, and what can we do as a collective to go further. I think for me, that is the starting point. Okay. Once we get it from there, then we'll get it right.
Okay.
Yeah.
Being deliberate. Timothy?
Yeah, I think maybe in the context of what we're speaking about, I think for me, an ideal situation, or where I would say that the country is taking the lives of women very seriously, would be a situation where a woman can be able to, one, access quality maternal health care, that they can be able to walk into a facility and get the service that they need. They can be able to access it not just from a point of physical access, but also from a point of financial access. That it is not out of reach for them to be able to access quality maternal health care, in that it is punitive in terms of the amount of money that they're paying. Is that whatever little that they have, they can still be able to, walk into a facility, get the health care they need, and they leave. But also, resultantly, after that, we put in deliberate effort to ensure that the quality of care is mainstreamed from beginning to end. Is that from the moment you enter the system and from the moment you're coming out, you can feel that there's actually quality of care throughout. For me, that would be an ideal situation. And that is where we would say that we actually really, truly value the lives of women when it comes to maternity health care.
And it shouldn't matter where it is that you've gone for
Absolutely
that. Quality
not.
should be anywhere.
Whether you're doing it in Lodwar or you're doing it in the hearts of Karen, it should be
should
the
be the
same.
same.
Yes.
All right. Thank you very much, ladies and gentlemen. Angela Nguku, the founder and executive director of the White Ribbon Alliance Kenya, and Timothy Thondu, who is the legal advisor at the Center for Reproductive Rights. And I feel like we've just scratched the surface on having a conversation about, quality maternity care, quality maternal health care, and, why the lives of women matter. Thank you very much.
Asante sana.
Asante.